Good morning, everybody. Today's webinar, we have a large audience, large number of people attending today, registered. So we're just going to give everybody 30 seconds more to join, and then we're going to start promptly. We have a packed agenda and a great lineup of speakers. We hope that you will enjoy today's session. Okay, welcome everybody. To those of you who are just joining, we're giving everybody a few more seconds to join. It is a large audience that we're expecting today. Thank you for being here. Well, let's begin. We are at 2 minutes in. My name is Elma Johnson. I'm the coordinator of the Bold Public Health Center of Excellence on Dementia Caregiving. Welcome to all of you today, to those of you who are returning and those of you who are new to our programming. We are very excited about today's webinar, partnering with community health workers to support dementia caregivers. We will be exploring opportunities for public health today. Again, on behalf of our center, welcome. I also am the coordinator of the Center for Healthy Aging and Innovation here at the University of Minnesota. Before we begin all of our events, we like to ground ourselves in acknowledging that in the land and the space that we occupy physically and virtually, and acknowledging that the University of Minnesota, Twin Cities, is located on traditional, ancestral, and contemporary lands of Indigenous people. We are grateful for the land itself, to the land itself and to the people, and we take to heart and commit to action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. We hope that you're going to see these values reflected in today's conversation and our work. For those of you who are joining us for the first time, just a very brief overview of our center. The mission of the Bold Public Health Center of Excellence of Dementia Caregiving is really to assist public health agencies nationwide in developing their existing and kickstarting new programming to support family caregivers of people living with dementia. As a dissemination center, we do this in multiple ways. Three main ways are by promoting and improving access to evidence-based programs and promising practices in public health, by being a convener and facilitating connections between public health agencies and a variety of other partners and organizations who support family caregivers of people living with dementia. And finally, by providing tailored guidance and consultation and assistance to public health agencies on a variety of topics related to their dementia caregiving programming. Also, our center exists in the context of the larger Healthy Brain Initiative Collaborative, which is a group of partners funded by the National Healthy Brain Initiative and the BOLD Act of 2018. Our collective mission is to support and help build a national public health infrastructure to promote brain health, address cognitive impairment, and support family caregivers of people with dementia. I encourage you to visit our website here, scan this code to learn more about us. And as many of you are probably aware, earlier this summer, the newest Healthy Brain Initiative Roadmap was issued, which is a guidebook for public health agencies to improve brain health nationwide in their jurisdictions, and provides 24 actions agencies can implement together with their partners to improve brain health for the communities they serve. To give us an idea of who all is in the audience, we have a large group here today. I am going to launch a poll. Please take a second to tell us in what capacity are you attending this event today. It should show on your screen. I'm going to give a few seconds, everybody, to respond. Thank you for submitting your responses. So far, I'm seeing about 11-12% of bold public health agencies. Great to see you here, bold family. Also, about 6% of non-bold funded public health agencies from across the country. About almost 30% of community organizations, as well as followed by clinical professionals and interested caregivers. I am going to try and share it on my screen for everybody to see. I hope you're seeing it. This is who we have in the room. All right. Just a reminder reminders for today's webinar. We always try to make our sessions as interactive as possible, and whenever we can, we set them as Zoom meetings. But because of the number of registered attendees today, we really weren't able to do that in a meeting format. So this is a webinar. So please, in your Zoom menu, utilize the Q&A feature to submit your questions as they come up for our speakers. They will be addressed at the end of the presentation, or our speakers might be able to address them in the Q&A while others are speaking. At the same time, use the chat as your communication space to share comments, resources, links, ideas. We will be hearing, for example, today from two states on how they have leveraged Minnesota and California, community health workers, but we acknowledge that there's many other great programs out there that we could not feasibly summarize today. So please use the chat to share links to your programs, share what you are doing in the chat. And feel free to use your reaction buttons to make it as interactive as we can. And at the end of this survey, when you close Zoom, it will automatically share an invitation to respond to a survey. We greatly value your feedback. Please just take a couple of minutes to tell us how we did and share your ideas for future events. Finally, this session is being recorded. Slides and resources will be shared after the event with all those of you who registered and attended. So you will get all today's presentation later on. And without further ado, I would just like to welcome our great panelists today. You can see them here on the screen, in the order in which they will be appearing. Shelby is a senior analyst on the Population Health and Innovation team at ASTO. She manages ASTO's portfolios related to community health workers, rural health, and social determinants of health. Welcome, Shelby. Dr. Kirsten Reinschmidt is an associate professor at the Hudson College of Public Health at the Oklahoma University Health Sciences Center. Her work focuses on reducing health disparities, and she has worked with community health workers for the past 21 years. Here, her expertise includes CHW prevention interventions, the roles of CHWs in addressing diabetes, dementia, and emotional health, and CHW workforce development. Welcome, Dr. Reinschmidt. Next, we will hear from Ms. Prasida Kanal, who is the State Oral Health Director at the Minnesota Department of Health. Prasida obtained her dental public health residency at the University of Rochester in New York, and a mini residency in geriatrics and long-term care for the dental team at the University of Minnesota here with us. Welcome, Prasida. And last but not least, we will hear from Michelle Johnston. Michelle joined the California Department on Aging in 2022 as the program director for their dementia initiatives. One of the projects that she's managing is the CALS Connect, a program that we will be hearing about today, and that is training community health workers to implement UCSF's care ecosystem model in 3 California counties. We are excited to welcome our speakers today. I will hand it off here to Shelby without further ado. Welcome.
Thank you so much for the kind introduction, Alma. I'm thrilled to be here to provide an introduction into who a community health worker is, the core competencies of their profession, how public health can support their workforce, and finally, how public health and CHWs can work together to support dementia caregivers. Next slide. As a brief introduction into our organization, the Association of State and Territorial Health Officials, or ASTO, is a national nonpartisan organization that represents the states and territorial health officials and the agencies that they serve. Our mission is to support, equip, and advocate for state and territorial health officials in their work of advancing the public health and well-being. Next slide. Next, I'd like to provide a level set into who is a community health worker. To be sure, there are several definitions of a community health worker that are used across the country and the world, but the most widespread definition that has been published through the American Public Health Association. They state that a community health worker is a frontline public health professional who is a trusted member and/or has an unusually close understanding of the community served. This trusting relationship enables the worker to serve as a liaison, a link, an intermediary between health and social services in the community to facilitate access to services and improve the quality and cultural competency of service delivery. Within this definition, I've bolded a few words that you will see throughout this presentation that really gets at the heart of who a community health worker is and how they work within their communities. This can be accomplished in a variety of ways, but the idea of being rooted in the community in order to help others get the care and resources they need that maybe are harder to access is a cornerstone within the CHW workforce. Next slide. Now that we understand who a CHW is, we can start discussing the many roles that a CHW fulfills within their work. On the screen, you can see 10 CHW core roles that were identified by the C3 project. This project brought together CHWs, researchers, and other stakeholders to put forth a set of common CHW roles and competencies that can serve as the base of what a CHW does around the nation. You can see these roles and competencies come up in CHW legislation or even within job descriptions for CHWs. Within these roles, we can see the bolded words from the definition shine through. CHWs provide cultural mediation. They provide cultural appropriate health education, case management, and system navigation. They provide coaching and social support. They advocate for the individual and community capacity. They provide direct services to their clients, and they implement individual community assessments, conduct outreach, and participate in evaluation and research. The CHW workforce is incredibly diverse, and with that, there is no one name that CHWs use or identify with completely. One of our key partner organizations, the National Association of Community Health Workers, or NASHWA, conducted a national CHW survey called Data for Action, which I will reference throughout today's presentation. Within this survey, CHWs identified for themselves their chosen titles for their work. NASHWA reported over 87 titles used by CHWs. The most common titles used were community health workers, community health educators, case managers, navigators, community health representatives, outreach specialists, among many, many more. Next slide. Community health workers provide a bridge to marginalized or underserved communities. Through NASHWA's Data for Action survey, NASHWA identified 4 top populations that CHWs serve. These include rural residents, non-English speakers, individuals without insurance, and individuals with complex healthcare needs. When we think back to the definition of a community health worker, we know that CHWs serve the communities that they identify with. They serve the communities where they have a well-established level of trust and individuals comprising that community. And they often have gone through similar experiences, including the barriers to care that their clients are currently experiencing. That historical knowledge of the systems that they are navigating with their clients can result in improved health outcomes across many key communities. Next slide. Now that we know who CHWs are, the roles that they provide within their communities, and the populations they serve, we can look into the diverse settings and sectors that they accomplish their work within. Through the Data for Action survey, Nashua identified 5 main settings where CHWs accomplish their work. They include housing, community-based organizations, which I saw many CBOs on the webinar today, health systems, food insecurities, and health departments. Those CBOs had the highest concentration of CHWs working within their settings. Through the COVID-19 pandemic, we've seen more CHWs work within health departments, leading to increased interest in the research into the ways health officials and their agencies can support the CHW workforce. Next slide. With increased focus on CHWs during the COVID-19 pandemic, there's been increased interest within CHW certification and training. Certification can be done in a multitude of ways. Each state can have different certifying entities. They can be state-based or even private, as reflected within the above map. As varied as where certification takes place, this is also true for requirements. Typically, there is an educational requirement or experience requirement combined with a certification fee. This varies widely across what that certification fee could look like. It could be as little as $5 or $10 or go all the way up to $50. States also varied on how long their certification lasts before a CHW needs to reapply. The materials needed to reapply and any potential continuing education requirements. Everything is on a continuum and looks very different on a state or even community basis. However, not every state has chosen to certify. Louisiana and Wisconsin are states that considered certification but declined to certify CHWs, and instead, they chose to build out their CHW training infrastructure. In most cases, introductory CHW training focuses on the core competencies and roles outlined in the C3 project we discussed above, but CHWs can also receive on-the-job training depending on their place of employment that is more specific to their work. They can also pursue individual opportunities to train in areas that they are passionate about or an area that they see a gap within their community that needs filled. Nashua also asked CHWs about their training experience through the Data for Action survey. I won't go through the entire bar chart, but we can see that there is quite a variance across the types of trainings CHWs have taken, even within that core competency area. Next slide. Moving to our next slide, as previously discussed, the CHW workforce is an incredibly important frontline workforce that public health agencies can help support in many different ways. On this slide, we've briefly outlined a few different objectives that public health can focus on to support CHWs working within their jurisdictions, along with actions that public health can take to accomplish these objectives. So the first objective that we have is CHWs hired into the governmental public health workforce. An action that public health can take is to focus recruitment efforts at community events and conduct group hiring events. And they can also partner within CHW networks to determine which job titles and career categories align best with nationally recognized CHW roles and competencies. Next, we have financial sustainability for CHW positions across sectors. Public health can partner with CHW network organizations and Medicaid organizations to secure Medicaid reimbursement for CHW services. Robust CHW workforce development and training. Public health can develop training and certification programs based on the CHW needs, experiences, and goals. They can also contract with local and state CHW networks organizations to support workforce development strategies, including expanding and deepening CHW networks. And finally, centering CHW voices in policy and program development. Public health can use a collaborative approach to developing and implementing CHW policies. They can also follow APHA guidelines for membership on all CHW committees or in work groups to ensure that 50% of those committees and work groups are made up of CHWs. Next slide. Finally, to provide an introduction into how CHWs can support dementia caregivers, I have taken a few of the CHW core roles that we reviewed earlier in this presentation and identified actions that CHWs can do to help support their dementia clients and their caregivers. Within all of these areas, it's so important to note that CHWs can and should provide direct support for the caregivers themselves, as well as the dementia patients that they are serving. We know that caregivers often struggle to maintain their physical, mental, and emotional well-being while managing their caregiving duties and other responsibilities. CHWs can be an excellent support to help caregivers maintain their own health, which, as you all know, is so important. So the first core competency we have is care coordination, case management, and system navigation. CHWs can provide caregiver support both in managing medication lists, scheduling appointments, and making connections to medical and social services, and supporting the well-need of the caregivers themselves. They can also support patient transitions between care settings. For providing coaching and social support, CHWs can take time to meet with the caregiver to discuss their needs, to plan for the next week and month with new appointments coming up, just making sure they have a plan for the caregiving plan. And they can also discuss opportunities for professional support, whether that be with a therapist or counselor, and peer support groups. CHWs can also provide direct peer coaching for the caregiver and direct support to empower the caregiver to prioritize their own physical, mental, and emotional well-being. Next, we have advocating for individuals and communities. CHWs can provide advocate support role when discussing care plans and next steps for the patients. They can also serve as an intermediary between the patient and caregiver and the health system to build trust. For building individual and community capacity, CHWs can provide relevant training or resources and referrals to the relevant training if they do not have that training themselves for the caregiver so that they can adequately support the needs of their loved ones confidently. They can also identify individuals within the community who are maybe showing early signs of dementia, and they can make referrals into screening providers. And finally, for providing direct services, they can support caregivers by providing home-based tasks such as blood pressure or ensuring patient is adhering to medication for both the dementia patient and the caregiver to support the physical, mental, and emotional well-being of all CHW clients. They can also attend appointments with the caregiver and the patient to provide that direct service to the patient. Next slide. And now, thank you so much for listening to my presentation. I hope that was helpful in providing an introduction to CHWs and how public health can partner with CHWs to support dementia caregivers. With that, I have my contact information listed on this slide. So if you have any questions, feel free to reach out to me via email or LinkedIn. I've also included 2 helpful links that you should be receiving once the slides are sent out. We have our ASTO homepage for community health worker products that we have published over many years. And then I have also included NASHWA's website, which has an incredible amount of information. So with that, I'll hand it back over to Elma.
Thank you very much, Shelby, for the great introduction to the CHW role. I would like to turn it next to Dr. Reinschmidt, and we will hear now about leading new training program, dementia-focused training program from CHWs that was recently developed in Oklahoma that can hopefully serve as an example, as a leading example for other states. Dr. Reinschmidt.
Thank you very much for the introduction, and thank you very much, Shelby, for this great description of the CHW workforce. So thank you for inviting me too. Yes, I would like to introduce the training that we have developed for CHW specifically to address dementia. And if you look at the next slide, you can see that I would like to start out with a little bit of background information on why this training was developed, and then give an overview of the training before I share with training based on the 10C3 project roles that you just heard about, how CHWs can support dementia caregivers. So to begin with the next slide, I will provide some background information on CHW programs that are addressing brain health, dementia, and caregiving. And before I do that, if you would use the chat to share what, if you would like to use the chat to share I'm sorry, my tongue is totally twisted. Let me try this again. I would like to invite you to share your knowledge of CHW or CHR programs, CHR being tribal CHWs, of any training that you know related to brain health, dementia, and caregiving. Next slide. Next slide, please. Studies have shown that CHWs are effective in improving chronic disease management and in reducing chronic disease disparities. Now, studies are also beginning to show that CHWs are effective in supporting the caring of aging populations. A recent scoping review showed that CHWs have the potential to address dementia on several levels. They have assisted individuals with assessing dementia care services and resources, and they also are helping to promote healthy aging and risk reduction. CHWs have offered education and support for caregivers, and they have provided awareness and screening at the community level. And you see a lot of the references I'm here to share with you to support those statements. In the next slide, you can see that there are training models that address, no, that needs to go back, please, to the slide. This one, yes. There are existing training models for CHWs that address brain health, dementia, and healthy aging that are linked to specific programs. And in those trainings, CHW learn things about dementia that are basic, maybe risk factors included, impact on the community, community services, and educational resources. And these trainings may also cover how to support persons with dementia and their caregivers. But with the training that we developed, we now have a comprehensive role-based training that supports CHWs in addressing dementia. This training prepares them in all of the 10 core roles that you just heard about. And upon the completion, the CHWs receive a dementia-specific certification. In Oklahoma, we don't have certification of CHWs, so we provide a certification of completion. But in other states with CHW certification, that could be a continued education certification. So now I move on to introduce the actual dementia training that we developed in Oklahoma. If you look here on this slide, you will see on the left those 4 squares that you can see that nationally, Oklahoma ranks very low in terms of general health outcomes and outcomes for older adults. There's very high increase of Alzheimer's disease and related deaths in Oklahoma. This may be related to the state being rural, with about 2/3 of the seniors being geographically distanced from specialized geriatric and neurological care. In addition, the lack of geriatricians and the predicted need for these specialists is something to be worried about. On the right, you see 4 squares where you can see that nationally, Alzheimer's disease is projected to nearly triple and affect minority populations disproportionately. In Oklahoma, aging populations are diverse, and we have 39 federally recognized American Indian tribes. While we don't really know the current extent of dementia disparities in the older population in our state, some of the county-based data shows that Alzheimer's disease among American Indians, for example, was significantly higher than at the state and national age-adjusted rates. So these combinations of factors called for CHWs to receive training to help address dementia. As trusted members of their communities, the CHWs can support dementia prevention and care in culturally sensitive and relevant ways. And so on the next slide, we see that this is where the Oklahoma Dementia Care Network comes in. The OKDCN is a HRSA-funded geriatric network enhancement program. This is a network of over 25 partner organizations that aim to address unmet health needs of Oklahomans with Alzheimer's disease and related dementias and their caregivers by providing health and public health workforce education, including this dementia training for CHWs. I'm showing you on this slide the logo and the link to our website, where you see all the different trainings that we offer, and also a brief description from our website. The CHW training falls under the fourth goal, which is to deliver community-based education and training to improve dementia care and support. So within this context, we developed and implemented the training for CHWs to increase their ability to promote brain health, be familiar with dementia, refer care and to care and community resources, support the care of persons with dementia and their family caregivers, and also help create dementia-friendly communities. And the next slide shows you a little bit more information on the training that we developed in partnership. And those partners include within Oklahoma, some of the tribes, health departments, and the Alzheimer's Association. This dementia training combines knowledge gained from the CHWs and CHR partners in Oklahoma, the national CHW core recommendations, and the evidence-based dementia care strategies. The national CHW core roles are based on the C3 project, and the evidence-based strategies are from the Alzheimer's Association, the CDC, HRSA, and the Mayo Clinic. The training consists of a train-the-trainer training, and also includes the materials that are passed on to the trainees. And upon the completion of the training, as I said, CHWs will receive a certificate of completion after about 6 to 8 hours. If they add another 2 hours with additional information on how to implement the training, they get the train-the-trainer certification. And here on this slide, you see that the CHW support for caregivers is actually woven throughout the entire curriculum. So we structured in the roles, the section on roles of addressing dementia, we used the 10 C3 project core roles to structure the training for the CHWs. In the training, we define each of the roles, explain it, and then give examples and invite the trainees to engage in the activities. On the next slide, you see on the left that over the past 3 years, we had 12 trainings with 234 participants based on the completed demographic survey. Most of the trainees were female and ranged in age and identified as American Indian or followed by white, and most were non-Hispanic. On the right-hand side, you see the first time that we opened the training at the national level, so beyond Oklahoma, we had 160 training registrations, and then ended up with 96 trainees being certified as certificate of completion recipients. The largest groups of trainees came from Arizona, California, Louisiana, and New Mexico. Now, why would we want to provide a training for CHWs to address dementia? And I talk about this on the next slide. Our initial assessment showed that our training is feasible. It increased the dementia knowledge and awareness of resources among the trainees, and the CHWs were effective trainers to their peers. We are in the process of analyzing data from all of our training to assess the effectiveness of the training. And we are really happy to share that there is an increase in knowledge that was statistically significant. The training also is relevant to integrate CHWs into dementia care teams, because the training offers so depending on the organization, the CHWs can play the various roles from within the broad scope of work, there are 10 core roles, right? As team members, they can support dementia prevention and care in culturally appropriate ways, and thus help reduce the health disparities and promote health equity. The training is also the first step to create sustainability for CHW programs that include addressing dementia, because the training provides a professional standards for the CHWs. But that said, before CHWs can address dementia in their workflow, the organizations that work or hire CHWs need to support them in terms of practicing their knowledge and also in terms of finding funding for these roles. So in the next and last section, I am introducing the actual work, what I think the CHWs can do in terms of addressing and supporting caregivers of dementia. And those roles can be either directly or indirectly in support. And so in each of the slides, I will name the core role. And on the left, you will see what this role is about. And then on the right, I show you materials from the curriculum or adapted materials from the curriculum. Again, I'm inviting you with this slide here to share any of the roles that the CHW CHRs play in your programs, or maybe you have examples that you would like share in addition to what I'm sharing with you. So in role number 1 on the next slide, there is a challenge in providing culturally competent dementia care, and this is by establishing a mutual understanding between the health and social services and then the community members. CHWs are in the intersection of the community and the systems that provide care, and thus can act as interpreters. People living with dementia, their caregivers and families need guidance to navigate complex dementia systems, care systems in culturally meaningful ways. So CHWs, for example, can include family members and caregivers in developing care plans for their loved ones with dementia. Role number 2, because the CHWs are from the communities they serve, they can deliver information in culturally meaningful ways. In the first section, Basics on Dementia, the CHWs learn basic information about dementia and thus can provide education and educational resources to caregivers. The CHWs will know about cultural beliefs and practices related to caregiving, and they can gear information towards these beliefs and practices. CHWs can also reduce stigma about dementia as part of this. The CHWs can make sure that the information provided to caregivers is presented in culturally appropriate ways. For example, storytelling may be the way to pass on information in some of the cultures. The CHWs will also know how to engage caregivers in culturally sensitive issues, such as care option and end-of-life care. Role number 3 addresses care coordination, management, and system navigation. The CHWs have fully integrated into multidisciplinary care teams can support care ordination. They will have the time, trust, and the cultural knowledge to help identify caregivers, help caregivers build a support network, and ask the caregivers what help they need to support people living with dementia. The CHWs can collaborate to develop and implement care plans as part of the case management. They can help remove barriers to care by identifying the caregiver's current concerns, and then also identify what resources are out there that can support and address those concerns. In terms of system navigation, CHWs can provide effective referrals to clients, to health and community services to ensure continuity of care. And with effective referrals, I mean referrals to services that are active and up to date, and that CHWs also follow up on with their clients, whether the clients actually were able to receive those services. Role number 5 is about support. The trust that is built between the CHW and their clients enables the CHW to provide coaching and social support. Providing people living with dementia and their caregivers with emotional support could help elevate their mood. For example, CHWs can validate clients' feelings by asking open-ended questions, by listening and showing that they care. The social support can be provided through support groups. CHWs can lead those groups either for people living with dementia or for their caregivers and help them through difficult times. Coaching can be especially important for those who care for a spouse with dementia. And the CHWs can employ coaching strategies. For example, they can model appropriate ways to respond to challenging behavior of people living with dementia, or they can help clients and families find balance in their lives and learn new ways to prioritize the self-care. Role number 5 is about advocating. And all CHWs are advocates, and they advocate on different levels. They can advocate for people living with dementia and encourage the caregiver to motivate their loved ones to live life as independently as possible. And this might also benefit the caregivers. The CHWs can help create environments where people living with dementia and their caregivers continue to be included in social networks, and they can advocate for caregiver needs and connect caregivers to the needed resources. The CHWs also can work at the community level to help create dementia-friendly communities that benefit both the person living with dementia and the caregivers. Role number 6 is about capacity building. CHWs build capacity in individuals and communities that benefit people living with dementia and caregivers. The CHWs can help select satisfying activities. For example, they can suggest to caregivers to build on activities that their loved ones with dementia used to enjoy. And at the community levels, the CHWs can help create dementia-friendly communities that are safe and supportive in terms of neighborhoods, for example. In role number 7, CHWs can support clinical operations by providing direct clinical and community-based care. As part of this role, CHWs can meet the basic social determinant of health needs of the caregivers, for example. They can bring a bag of food from the clinic's food pantry while making a home visit, for example. Role number 8 is about assessments. People living with dementia may have difficulty making decisions, which puts them at risk for accidents and injuries in the home and beyond. So caregivers may not be aware of those safety risks or when to intervene with their loved ones. The CHWs can support givers by assessing hazards in various contexts and by providing risk prevention education to the caregivers. Role number 9 is about outreach. Outreach activities can benefit caregivers directly or indirectly through case finding, follow-up, home visits, or community presentations. Engage in coordination or presenting of health fairs. CHWs can directly reach caregivers in the communities where they are. CHWs can also organize community programs for seniors. That includes people living with dementia and their caregivers. And last but not least, role number 10, CHWs can engage in program evaluation and community-based participatory research with a focus on benefits to or needs of caregivers. Due to their relationships with their clients, the CHWs can collect valuable information about and for the caregivers by facilitating focus groups or collecting caregiver stories. CHWs may also identify caregiver case studies. For example, case studies that can then be used in project echo sessions that focus on supporting caregivers. And with that, on the last slide, I'm thanking you for your attention and the opportunity to share about our work. And I will be happy to answer questions that come up towards the end of the session. Thank you very much. I hope that was helpful.
Thank you, Dr. Reinschmidt. It really was helpful. It was an outstanding overview. Thank you for sharing about your training and for really outlining for all of us really the many different ways in which community health workers can support the person living with dementia, the family caregiver, and really the family that supports them. So next, we are going to turn to 2 state case examples. First, we'll be hearing from Minnesota and then from California. And as we go into this final section, please think about, and if you can feel free to answer to the question that Dr. Kirsten asked you. What other training programs there are in your states, in your jurisdictions, and feel free to share links and any more details with the group. Next, I am going to hand it up here to Presida. Welcome. Thank you.
Thank you, Elma. Good morning, everyone. My name is Prashida Knal, and as you know, I am the State Oral Health Director at Minnesota Department of Health, or MDH. I'm pleased to be here today to share with you how MDH is protecting the oral health of older adults, specifically of people living with dementia. Next slide, please, Elma. Thank you. I will be sharing our boots on the ground experience with the Healthy Brain Initiative, a project that utilized our training of trainer model, as you can see on my slides, to educate the community health workers and reach caregivers of people living with dementia. In my presentation, I will also share with you the lessons learned and opportunities for us to make a larger impact. Next slide, please. The CDC and the Alzheimer's Association conceptualized the Healthy Brain Initiative to really bring a public health perspective to the promotion of cognitive health. The National Public Health Roadmap comes at a critical time, given the dramatic aging of the US population, the scientific interest in the association of oral health and dementia, and the growing inequities in geriatric oral health care. Next slide, please. So whenever I think about growing inequities in geriatric oral health care, next slide, please, Elma, I think of Mary Otto's book, The Teeth. I'm sure many of you might have already read this book that talks about a very bizarre situation. Here in America, we treat the mouth separately from the rest of the body. It's a very bizarre situation. And oral care is separated from medicine's education system, insurance, physician networks, medical records, and payment system. Whether you have health insurance is one thing, and whether you have dental insurance is an entirely different thing. Your doctor doesn't ask you if you are flossing, and your dentist may not even ask you if you're exercising, right? Next slide, please. But the issue here is that the body didn't sign off for this arrangement, and the teeth don't know that they are supposed to keep their problems confined to the mouth. And that's why it's so important for us to talk about the mouth-brain connection. As some of you may already know, or many of you may not even know, that the mouth is home to over 700 bacteria, and some of these bacteria are responsible for causing the gum disease. There was a recent study, a very large study, that suggested that bacteria that cause the gum disease are also associated with the development of Alzheimer's disease and related dementia, especially the vascular dementia. The results were also reported in the Journal of Alzheimer's Disease. So as you can see on my slide, if someone has dementia, it increases the oral health complications leading to preventable oral diseases. And if someone already has oral disease, it increases the inflammation, which leads to more rapid dementia progression. So there is really a bidirectional relationship or association between the mouth and the brain. Next slide, please. But because of a lack of coordinated public health approach to preventing and managing oral health disease, 42% of our nursing home residents in Minnesota have dental care need. 3 out of 5 older adults have fewer than 20 teeth that is even considered as a functional dentition, which is really an equity issue. If you look at the national trend in oral health, more older adults are living longer. They're also retaining natural teeth, but 96% of them have at least one tooth decay, and 68% of them have gum disease, which is the risk factor for dementia as well. So what happens with these kind of inequities that we are seeing in oral health is that as a state, we are spending too much on the emergency rooms. We are really spending a lot on hospitalization for preventable problems and less on preventive and timely routine restorative care to people. So bringing a public health perspective to mind, body, and health, or really trying to put the mouth back in the body, really requires an inclusive and strategic approach. Next slide, please. So even though there is so much to celebrate in oral health improvements, unfortunately, many older adults still suffer from chronic oral conditions and lack of access to dental care they need both nationally as well as in Minnesota. Next slide, please. So these barriers to dental care access are related to barriers in seeking care, reaching care, and receiving care. Next slide, please. So against this backdrop, for us to focus on the training of trainer of community health worker was really evidence-based. So research suggests that dementia has a negative impact on oral health and vice versa. This is largely based on studies with dental professionals or secondary analysis of quantitative data. However, very few studies look directly at the experiences and views of those people who are living with dementia. Furthermore, these studies have been really geared towards institutionalized setting or the nursing home, right? Even the open mouth assessment data that I shared with you earlier was also based on nursing home, participants. And we found out that more than 90% of those residents were Caucasian. So we don't even know if there is a disparity between different racial and ethnic cohorts. So the rising rates of dementia amongst an aging community dwelling population retaining their teeth into old age suggests that the focus should now move to communities. People with dementia are susceptible to full range of oral disease, starting from tooth decay to gum disease, the prevention of which absolutely depends on good daily self or assisted care underpinned by regular professional care. The potential impact of dementia on oral health is thus compounded by the fact that the ability to perform daily self-care may be undermined by impaired cognitive functioning, and access to professional care or access to dental care in a community setting may not even be straightforward. So those were the reasons why we really felt that we had to focus on community health workers and training them to reach the caregivers to support the promotion of geriatric oral health. Next slide, please. And on top of that, the graying of America is real. And in Minnesota, as we see a growing number of older adults, they continue to be an important part of the society, volunteering and, they really like voting. They are one of the major groups of voters. Next slide, please. There is also increasing impact of cognitive decline, but the issue here is that we see a lot of inequities in how we are screening, or inequities in which communities are getting screened for cognitive impairment. So for example, non-Hispanic Black adults, Hispanic adults, and likely American Indians are more likely to have Alzheimer's and less likely to be diagnosed is another issue why we have to focus on community health worker. So as a Minnesota population ages, dementia is going to be an increasingly large part of the conversation, both in public health as well as in dental public health. Next slide, please. The number of caregivers are rapidly increasing in Minnesota, and they play an important role in routine care of people living with dementia, but they may not even have the skills and knowledge to support the people living with dementia. So that is the reason why community health workers are so important. Next slide, please. So if you really look at the socio-ecological model in public health, one thing is very clear, that even though all the older adults are susceptible to dementia in one way or the other, there is always those social determinants of health that also play an important role. I get a lot of calls from, caregivers talking about access issue to dental. There are so many stories that I hear on a daily basis. And what I hear from them is really lack of oral health care provision within those packages of care, the difficulty finding out about and accessing community dental care, and the reliance on relatives with the knowledge, skills, or resources to make the necessary links all contribute to the poor oral health and lack of access to care. So those are the stories that we've been hearing sort of every day from people or caregivers who are supporting people living with dementia. So community health workers could really help us close the medical dental divide and put the mouth back in the body. And that's our aspirational hope. Next slide, please. And we already heard from other presenters about how community health workers could contribute overall for people living with dementia, but in oral health specifically, they can serve as a critical linkage between the community and utilization of oral healthcare services, especially for people living with dementia. Next slide, please. So our training of trainer model was a pilot we did with the funding from Healthy Brain Initiative campaign. Next slide, please. And I'd like to give a big shout out to Monisha Washington, who was our lead community health worker in this project. And I can talk a little bit about the framework in the next slide, please. So what we basically did was we worked with Volunteers of America and trained their community health workers. We basically took a common risk factor approach to really integrate oral health into the bigger public health system, and also to tie oral health with dementia. So then it just paints a holistic picture of health. And we were also approached with more seriousness, because sometimes it's very hard to get that buy-in when you go into communities and try to talk about oral health. So it really helped us to take this common risk factor approach. So once we trained the professionals from Volunteers of America, including our lead CHW, Monisha, she organized a breakfast with caregivers where we had over 75 caregivers, predominantly from African American communities, come to that event. So one thing that really was clear to me at this particular event was that I trained Monisha to go and train other caregivers. But when she was training the caregivers, she did not start with oral health presentation. First, the caregivers were, praying around the food because it was breakfast with caregivers. Then there was a lot of talking about being women and also being caregiver. So that kind of, bonding and that cohesiveness, or that kind of cultural competency that our community's health worker add to the formal training we have for caregivers helping people living with dementia, it's unmatched. That's why I feel like even though this was a pilot, it has really helped us set the tone for our future work. Next slide, please. We used evidence-based approaches. Most of our modules were all based by literature and guidelines. And we really wanted to make sure that we were using messengers of communities such as community health workers. And the idea was really to promote community clinical linkages. Next slide, please. So what did we accomplish? We accomplished a sort of a framework. We have a framework. At that time, we were not really sure of evaluation. Now we've reached to a point where we know how to conduct pre and post evaluation and match the data. We were able to train both professional students as well as professionals. We also developed flip charts. And even now we continue to use this model. That was our big accomplishment. And we also understood community, right? The authentic community engagement that we learned, the how do you adapt the oral health materials to make it more tailored to your audience. I think those were really valuable lessons we learned from this project. Next slide, please. Our case study was also published by Alzheimer's Association and Association of State and Territorial Health Officials, as you can see on the slide. Next slide, please, Elma. Next slide, please. So one of the key lessons we've learned is a clear pathway for entry into the oral health workforce and reimbursement for education, preventive services, and community clinical linkages must be considered. These pilots should not be limited to grants and funding. It should be really part of our reimbursement system. So we are talking about sustainability of community health worker model. Next slide, please. So future direction, we try to build a dental public health system where we have the focus more on equity at the center, but we also know from the iron triangle of healthcare that if you are trying to increase the access, the quality and cost are going to get compromised. So with that in mindset, next slide, please. We did receive Age-Friendly Health System grant from HRSA, and we're going to focus more on 4 M's. which is one of the components of those 4 M's is really mentation. So we will continue to do a lot of work around dementia and oral health. And one of our initiatives is really to train competent workforce, which is our dental professionals, and also to make our dental clinic more age-friendly. Next slide, please. So just to summarize this slide, looking at that time, we need to work upstream for greater impact to increase the screening for cognitive impairment. We can also work with our partners to really make sure that there is a bi-directional referral system with community housings. And that's one of the projects that our lead community health worker is doing, where we are trying to mobilize community health workers to go more into those high-rises or community dwellings to reach people who are in non-institutionalized setting. Next slide, please. So this is an important map that I wanted to quickly share with you. The use of GIS to identify naturally occurring retirement communities in dental professional shortage area as a proxy for high-risk communities has really reframed MDH's approach to promote healthy aging. And with this map, we know where older adults are living, and we know if these counties were meant to be, older adult friendly. And we also know those areas where older adults are living, and those areas are designated as a dental professional shortage area. So potential CHW intervention efforts can be tailored to specific community needs. So this map, the North map, has been overlaid with the professional shortage area map, and areas in common may be an opportune communities for community health workers trained in older adult oral health to establish community clinical linkages. So for the first time, we officially know where to target or which communities to target. And that helps us really broaden our scope in terms of reaching older adults who are not in long-term care facilities. Next slide, please. Everything that we are doing is really system level approach, because again, as I mentioned earlier, we are looking at system level change, not just doing work because there is money to do it, right? We just want to make sure that there is interagency collaboration. We are talking about place-based strategies, and maybe really securing sustainable funding to make this work integrated into broader public health system. Next slide, please. The community health workers would have more opportunities to connect with people living with dementia in newer ways, because now we have greater tools for prevention. We have teledentistry. There is a push for adult dental benefit in Medicare, and there's also a lot of momentum to move towards value-based care. So these are the future opportunities that would really help sustain our community health worker efforts. Next slide, please. So at the end, it's really important for us to not just tell the different version of the same story. We have to change the story. And one thing that I've personally learned from this project is that when we are asked to think outside the box, in the first place, there's no box. There's no limitation as to how much we can think and be innovative with community health workers. Next slide, please. So as Mother Teresa said, I alone cannot change the world, but I can cast a stone across the water to create many ripples. So the ripple effect of our work has been much greater than we had imagined. And I really invite you to join the conversation about institutionalizing community health workers in geriatric oral health promotion. Thank you.
Thank you, Cressida, for a great overview of this program in Minnesota. And now I'm going to turn to Michelle, who is going to give us an overview of the CALS Connect program in California. Welcome.
Yes, I'm happy to be here. Thank you to talk about CALS Connect, and thanks to all the great presenters who came before me. So you covered a lot of territory. So I'm going to wrap up with just another example of what's being done in a state that could be replicated, or it could be applicable to other states and counties. So what I'm going to talk about is just the overview of our CALS Connect project. This is a cooperative agreement grant that we've received from the Administration for Community Living as part of their Alzheimer's Disease Program Initiative Grant Series for state entities. So the overall goals of the ADPI grants are to create and sustain a dementia-capable home and community-based services system for people living with Alzheimer's disease and related conditions and their caregivers, using a no wrong door approach. And then the second bullet is the one I'm going to focus on most today, and that's to ensure access to a comprehensive, sustainable set of quality services that are both dementia capable and provide innovative services to people living with dementia and their caregivers. Next slide, please. So the project partners for this project, California Department of Aging, we were the primary recipient of the grant. And then we have contracted with 3 pilot counties. Each of these pilot county agencies serves older adults and people with disabilities through a designated or developing aging and disability resource connection program. And we selected these sites for their strength of their existing programs and for the geographic diversity representing the northern, central, and southern parts of our state, including rural communities. And so by utilizing these aging and disability resource connection programs, this approach gives us streamlined access to dementia care information and supports, and helps to ensure that those served have access to a recognizable hub that offers resource navigation and assistance in care planning. So we have our 3 pilot sites in Imperial, Marin, and Ventura counties, and then we have contracts for clinical support services to assist those community health workers, and that's through Partners in Care Foundation, who is providing our medication reconciliation piece through their home meds program, as well as the nurse to provide clinical support. And then Alzheimer's Los Angeles is providing the social worker for the clinical support team. And then our outside evaluation group for this is the GIGAS group. Next slide, please. So the approach that we're taking for this project is to offer a program that was developed through UC San Francisco. It's their Care Ecosystem program. Care Ecosystem is an evidence-based program. It's typically offered within a healthcare setting, and we're taking it out into a community setting for this project. So our program will be staffed by bilingual community health workers who are trained as the care team navigators. And these community health workers will be providing specialized dementia education, working with the dyad, so both the person with the disease and their care partner, to develop a plan of care, to connect the participants with community supports and services, and to aid in care transitions. Next slide. So this gives you a picture of what the UCSF Care Ecosystem model looks like. So in the middle of the circle, you have your dyad, the person living with dementia, and their care partner, along with that care team navigator, who for our project, we're using community health workers. They connect out in the system with community resources and healthcare providers. And then there's that clinical support team at the bottom with expertise in nursing and social work and pharmacy. And so the care ecosystem model really focuses on the person with dementia and their caregiver, people whose quality of life can be improved and whose preventable hospital use could be reduced through that support, through linkages to other resources, advanced care planning, and care coordination. And so the dyad, the person living with dementia and their caregiver, the caregiver can be a family member or a friend, even a paid staff person who supports the person with the disease and who's willing to participate in the program. And the community health worker really actively supports that dyad. So all of the speakers have talked about the different roles that community health workers play. So they're really going to be helping to empower the caregivers to leverage the protocols and resources available through the care ecosystem model, and to provide that information, and then to liaison with the clinical team members. Next slide. So this shows you some of the care ecosystem protocols. So the community health workers are completing site-specific training, and so their care delivery is guided by the protocols of care ecosystem, but it's a very flexible model in that it's based on the needs and the interests of the person with the disease and their care partners. So it's a model in which you can do these different protocols in a variety of orders depending on what the needs and interests are of the people that you're working with. And so those resources are really provided on an as-needed basis that's both proactive and responsive to the needs and interests of the dyad. And the community health workers can provide resources to decrease caregiver burden and address the needs of the person with the disease. The care ecosystem model is designed to be delivered remotely, so phone and or Zoom based, so no home visits required. And then for the medication reconciliation and review piece, we are using home meds, which is also an evidence-based program. And so that will help to identify issues related to medications. And we're offering that both to the person with the disease as well as to their care partner, because often they have medication issues as well. And that will involve pharmacist consult and recommendations where the system flags potential issues. Next slide. So why community health workers? The UC San Francisco model is a model that really is very amenable to the use of community health workers. The care team navigators, as UCS describes them, they don't need to have a college degree or specific healthcare related background or certifications. The key attributes of a successful community health worker are really those excellent communication skills and the ability to build rapport and communicate with the dyads in their preferred language. And so the way UCSF has laid out this model, it really seemed to be a good fit for community health workers. Their care team navigator positions receive training in a range of dementia care topics. They have access to a library of resources along with the clinical support team. So the other reason that we are using community health workers and calling them that in this project is we also feel that community health worker is a title that's more commonly used in the community. So people are more likely to be familiar with knowing about a community health worker than knowing about a care team navigator. And so we're using that title. And then the other thing about it, and people I know have been exploring this in the Q&A, and I'll drop this link in the chat right now too, is that Medi-Cal in California, our Medicaid program, has launched a community health worker benefit. They launched that in July of last year, and it covers community health worker services as preventive services and on the written recommendation of a physician or other licensed practitioner. They may address issues that include, but are not limited to, a long list of things that includes the control and prevention of chronic conditions, as well as issues related to aging. The community health workers may assist in developing a plan of care with a licensed provider, and they may be supervised by a community-based organization or local health jurisdiction that does not have to have a licensed provider on staff. So we feel like this really may provide an opportunity for sustainability of some of the programs and services that we're providing. And so we're really trying to align ourselves with that model from the start. Next slide. So in terms of where we're at in the process, we're just starting the second year of a 3-year grant. So the first year was really about planning, securing the grant, contracting with our partners, updating all the plans, setting up the systems and documenting the processes that we're going to be using throughout the project for referrals and enrollment and the data collection. The pilot counties have been recruiting and hiring their community health workers. So we have 2 of our 3 sites have hired their community health workers and are in the process of training them. We're also training the agency staff who will be handling the referrals. The nice thing about working with our AAA and our independent living center staff is that they have a set of staff already who respond to inquiries related to programs and services in the community. And so those folks will be handling the initial screening and connecting folks with the community health workers or referring them to other programs and services if they aren't a good fit for this particular program. It's a great, there's a great amount of resources available online through UCSF through their care ecosystem. And then we also have connections through our local partners. So we've been connecting all of those and then also developing the outreach materials and plan for the outreach that'll be conducted both in English and Spanish. Next slide. So we are on the cusp of starting our implementation. So our sites are getting ready to conduct outreach to promote the program. Our staff are getting ready to process those referrals. And our community health workers, their goal is to enroll approximately 240 dyads for each of our county sites over a 2-year period. And then we'll be conducting regular calls to assess the needs and provide education, to make referrals, to follow up on whether the folks' needs have been met, using all of the protocols and resource materials from Care Ecosystem. And then our community health workers will be collecting that information on both prescription and over-the-counter medications and supplements that will be entered into the home med system for the medication reconciliation, and then creating care plans for the families and updating them as needed throughout the process. Next slide. So then in terms of our ongoing monitoring and development, our clinical support team is conducting weekly huddles with the community health workers to go through case reviews, to conduct ongoing professional development, and to raise and address any issues that might come up. We'll be conducting training with our referral staff at each of the sites annually. And then our project team meets 1 to 2 times a month to assess our progress, to discuss best practices, identify issues, and plan for sustainability. We also have a steering committee that involves some outside experts who advise us on the project, and we meet with them quarterly. And then, of course, we implement our evaluation plan and provide the reports to our funder every 6 months. Next slide, please. So in terms of some consideration for public health or even for other community-based organizations who may be listening in and are thinking about how could we do this in our local area or in our state, a few things to consider. Are there existing community health worker programs in the area? So our colleagues in Minnesota were talking about how they tapped into some existing community health worker programs and were able to train them in this new area. So that's something you all could look at doing. Or on the flip side, are there existing programs that are supporting people with dementia and their caregivers where a community health worker component might be able to be added to that program, really to expand your reach and to work with people? Are there evidence-based program models that you can use? You know, we chose Care Ecosystem. There are lots of evidence-based programs out there for support for people with dementia and their caregivers. So finding the model that works right in your area. Do you want to provide the services remote or in person? So there are some programs out there that are very focused on being in person. There are others like Care Ecosystem that can be delivered remotely, which definitely helps with the cost and can also help, you know, in rural areas or places where it's harder to get to folks. And then who or where are you going to get the training from for the community health workers, and who will provide that ongoing supervision? So those are all kind of things to consider as you're developing the program. Next slide, please. And this is just a map, it's or a listing. It's a couple months old, so the implementation phase information may not all be up to date, but this is a list from UCSF of the different sites right now that are implementing Care Ecosystem. So I put that up here so that if you're from one of those areas, you know who to connect with to learn more about this program and what's going on in your area and how you can get involved. Next slide. And then I'm not going to go over these in detail, but UCSF has a lot of great results from folks who've been implementing Care Ecosystem in terms of improving caregiver well-being and reducing burden, improving patient quality of life, and then some financial savings too in terms of reduced emergency room visits and reducing Medicare claims cost of care data. So we're very excited to be implementing this here in California. Check back with us in a couple years and I'll have much more to share. But the next slide, and this will get dropped in the chat, is the information. Next slide for UCSF on the Care Ecosystem. And that is all I have to share. And I think since I'm the last presenter now, I think we're turning it over to questions. So we'll turn it back.
Thank you so much, Michelle. What a really great session. I know I've learned a lot. It's really incredible the opportunities there are for public health for collaborating with CHW programs, as they have seen, for funding to really driving forward training and developing of new curriculums specific to dementia and caregiving, and then really partnerships, as we have seen illustrated here by the Minnesota example, between different programs and in California, different agencies. While this work in California is led by the Agency on Aging, really, it's a partner and could be done also by public health. So these are great ideas. So please, everybody in the audience, do share examples from your own states, from your own programs, share with everybody. And we have a couple of questions in the few minutes that we have left that I would like to ask our speakers. From G.J. Hudson. Do any of the speakers know of any CHW programs focusing on LGBTQ+ communities, aging or otherwise? Are you aware of any? Or somebody in the audience, perhaps?
Not aware of one specifically, but I would check with SAGE, and I can drop their link in the chat because they've been doing some work with the Alzheimer's Association around LGBTQ+ older adults and Alzheimer's and other dementias. So if somebody's doing something, I bet SAGE knows about it.
Mm-hmm. Thank you, Michelle. And another question is, are CHWs facing any pushback as public health moves away from focusing on COVID? either the public health has done too much or not enough, or
I can answer that question
Mhm.
in terms of acceptance. In Minnesota, I feel like there's so many initiatives and advocacy going on for integrating community health worker into broader public health system that I don't think there are pushbacks at all. I think people are looking for more innovative ways to get them integrated into our system, but also making sure that they are sustainable. So I'm not seeing pushbacks. Instead, I do see a lot of coalitions and alliances and stakeholders group coming together to advance the conversation.
thank you. Dr. Kiasen, did you want to say something?
Well, it would just be a similar experience in Oklahoma. It is obvious that there was a lot of benefits of working with the CHWs during the pandemic. And so their efforts of making those programs more sustainable and figuring out maybe how to reshift the focus of the CHWs so that the different organizations can maintain working with the CHWs. So yeah, just the opposite of pushback.
Mhm. Yeah, thank you. And Dr. Reinschmidt, also a question for you on the topic of training. Training modules exist broadly available for other chronic diseases, and while there is work across the country in dementia, there really isn't a repository or a central place we can all look to as a point of reference in terms of developing training curriculums for community health workers on dementia and caregiving, supporting people with dementia and their caregivers. Where should we be looking moving forward? You gave a great example in Oklahoma. It's a leading example based on professional standards for community health workers. What do you see coming on the horizon? What are leading organizations or agencies that are developing these?
I think the way that we structured our training by addressing the 10 core roles for CHWs with a specific disease focus, that might be something that is picking up across the nation as organizations and employers are becoming aware of the C3 project, the core roles. But those kinds of trainings, I would see them as a beginning training for CHWs to address a certain health condition within each of the roles. Then additional more intense trainings could be added. For example, I know that in Oklahoma, some of my colleagues provide bathing without battle trainings. So that is something that could be added on for CHW training, not that they would do the actual bathing, but they could use that information to educate the caregivers on how to work with their family members. So I think that is one way I would answer this question. The other answer I have is the National Association for Community Health Workers. They are collecting all kinds of information on CHWs, and they have, I'm lacking the word that I'm looking for now, they have like a depository, or they have files in which they collect different kinds of projects and work. So that would be a starting point to look at what else is out there.
Mhm. Thank you. This next question might be for you, Shelby. Generally, is there an education level of requirement to become a community health worker or a CHW CHR?
Yeah, I think that varies pretty widely based on state. Most commonly, we see at least a high school graduate degree as a requirement, but there has been a movement to look at what barriers are preventing people from joining the community health workforce. And if people are already doing that work, kind of looking and reassessing if that really makes sense to prohibit them from certification if they don't have that educational requirement. But I would say widely, a high school degree is the most common level.
Thank you. And another one here, is anybody aware of a CHW training program to train seniors to be CHWs for the senior population, that peer-to-peer training among the presenters or in the audience? Ms. Barcel asked.
I'm not sure of a training that's particularly designed for that audience. I do know, so one of the other ACL grantees, Alzheimer's Orange County, is actually implementing care ecosystem in a older adult living complex. And so their plan was to use people who lived at it's a 10,000 person senior community, to use folks from that community to serve as the community health workers for their care ecosystem project. So, but I'm not sure of a particular training that's just focused on seniors, but it looks like Jessica put something in the chat.
Yeah. Thank you, Jessica. Well, those are all the questions from our attendees that we have in the Q&A. And really, in 3-4 minutes that we have left, I would like to ask you, the speakers, do you have any question for the audience? Anything else you would like to learn for your own work, for your own programs?
Maybe, Elma, this is the time I have access to such rich audience. Maybe I could ask them their thoughts about putting the mouth back in the body and integrating, you know, the mouth and the brain health together. I think that's always a topic that's sort of not discussed in public health forums. So I just wanted to know what people were doing or what their thoughts were about, you know, putting the mouth back in the body. Even if I could get some feedback in the chat, or somebody wants to unmute, that would be really helpful for me.
Perhaps somebody, if you can raise your hand, I can see you here and I can unmute you in the time we have left. If you have anything you would like to share, let me know. All right, Marcy Getz raised her hand. I'm going to allow Marcy to talk. Go ahead, Marcy.
Yes, good morning, or I guess good afternoon, depending on where you're living. I just want to say that all the presentations were excellent. Thank you. And regarding the question about getting the mouth in the body, first of all, I thought that's such a great saying, and I was really impressed with that. But also, I think you continue to educate people on the connection between dental hygiene and health and brain health. I think that goes a long way. I just think a lot of times people aren't aware of it. So I would say just continue with what you're doing in terms of getting the information out, especially to public health folks.
Thank you, Marcy. Presida?
I just wanted to thank Marcy for sharing her perspectives.
Great.
Thank you.
Great. Well, we are getting close to time. Thank you so much. There's been a lot of feedback here in the chat. We're glad that you found this helpful. This is just the beginning of a conversation. The CHWs have such a key role in connecting the clinical and the community and the home really space for older adults, for people with dementia, their caregivers. They're in that special position, the trusted place where they can really make an impact in people's lives. And it's an opportunity for public health, for collaboration, and creating new partnerships for support to improve the brain health for all of us, for all the communities they serve. So thank you so much. Again, we hope this is just the beginning of this conversation. This is the role of community health workers in the continuum of dementia care, the progression of disease, is a topic of shared interest among the 3 public health centers of excellence. So do expect to see some work on that end from us as well. Thank you to our outstanding speakers. Thank you for sharing your work. Dr. Reinschmidt, Shelby, Michelle, Presida, it's a pleasure to have you here. All of the slides will be shared with everybody after the event. And we appreciate your feedback. When you close Zoom, please take a minute to respond to that survey. Tell us what you thought, what we did well, and what you would like to hear about in the future. And of course, what we can improve. Have a wonderful day, everybody. Thank you again for attending today. And we hope to see you soon again in one of our upcoming events. Again, thank you. Bye.